In this chapter, I would like to talk about the medical management for the patients with traumatic spinal cord injury. This is a little bit about me. I am a former postdoctoral fellow at Dr. Felling's laboratory, University of Toronto. Spinal cord injury has been a challenge that physicians face for a millennium. This is a severely debilitating condition leading to neurological dysfunction, loss of independence, respiratory failure, psychological mobilities, and an increased lifelong mortality rate. I would like to begin this talk with a case vignette to try to put the issues into the perspective. This is an 18 years old female patient that I treated with C6-7 fracture dislocation with sustained major compressive injury of the cervical cord. It's really unfortunate that there's nothing we can do to reverse these detrimental effects of this injury. But there have been huge advancements of medical management which could improve the quality of life for such patients. The learning objectives in my talk are summarized in this slide. I will be discussing some details of pathophysiology of spinal cord injury, and I will be discussing some detailed advances in the management of acute spinal cord injury, with particular focus on initial critical care and how to assess the classification of the patients with acute spinal cord injury. I am presenting a role of surgical intervention and evaluation of the role of corticosteroids, and also presenting this as a treatment option. I will discuss some details of complications after spinal cord injury, and I will be discussing a number of emerging treatments with particular focus on cell transplantation. And finally, I will discuss the prognosis of functional recovery following spinal cord injury. We can consider the patient that I presented with this severe cervical spinal cord injury. We recognize the mechanisms of acute traumatic spinal cord injury involve a primary injury based on this postmortem examination from a patient showing contusive cervical cord injury. On the right, this is illustrated that these are the images which depict the vasculature of injured cervical cord from a rodent that has been acutely injured. This shows the hemorrhage from the disruption of the vasculature with possible surrounding ischemia. These are the concepts of primary injury. The primary injury sets in motion a set of secondary injury events, and this is triggered by the resulting vascular injury of the spinal cord. And this provokes degradation of neurofibers as well as neuronal cell death due to the influx of calcium and excitotoxic mechanisms, and this is illustrated here in the progressive degradation of neurofibers and the infiltration of inflammatory cells shown by confocal imaging. And this combines final pathology in the chronic spinal cord injury with the central cavitation and the demyelination due to the resorption of hemorrhagic chronic tissue surrounded by reactive astrocyte, which forms a astroglial scar. This represents significant barriers to regeneration. In the acute phase of spinal cord injury, medical and surgical management such as immobilization, clinical assessment, and graphical imaging are essential to understand and minimize the effect of detrimental progressive cascade known as secondary injury. A potential cause of secondary injury following spinal cord injury is inadvertent mechanical trauma from manipulation of an unstable spinal column. Patients with unstable spinal column should be manipulated or treated with spine precautions, such as log roll with immobilization. The combination of a properly fitted rigid cervical collar with supportive blocks on a rigid backboard is effective at achieving a safe spinal immobilization for transport. Concomitant injuries in patients with polytrauma can be assessed with the Injury Severity Score, a 75-point scale involving 6 major organ systems that can predict the degree of injury, mortality, morbidity, and hospitalization time after trauma. Neurological assessment should proceed in accordance with the American Spinal Injury Association (ASIA) International Standards for Neurological Classification of Spinal Cord Injury. This scoring sheet was originally published in 1982, which is the most widely accepted classification system in clinical use. The ASIA Motor Score is based on the power of these 10 myotomes of upper and lower limb bilaterally rated by manual muscle test (MMT), ranging from 0 to 5. Sensory score consists of light touch and pinprick sensation, ranging from 0 to 2. Tendon and pathological reflexes and perianal sensation, boundary control, anal contraction, deep anal pressure, valvocavernosus reflex, anal wink should also be examined as initial clinical assessment. The neurological level of injury (NLI) refers to the most caudal segment of the cord with intact sensation and MMT3 or more points. Asia Impairment Scale (AIS) classifies spinal cord injury into 5 categories ranging from AIS-A to AIS-E based on degree of impairment. When we see the patient with spinal instability and neurological deficits, stabilization and/or surgical decompression should be considered to restore biomechanical stability to the spinal column and optimize neurological outcomes. Multiple classification system has been developed on the basis of injury mechanisms and radiographic features to serve as tools for clinical decision-making. They include the Allen and Ferguson classification and the Harris classification for cervical spine injuries, and the Dennis Three-Column classification and AO classification for thoracolumbar spine injuries. Here we introduce useful classifications: subaxial injury classification (SLIC), and thoracolumbar injury classification and severity score (TLICS) that the Spine Trauma Study Group has been developing recently. They have 3 components of the scoring system, including 1. Injury and fracture morphology, 2. Integrity of the discal ligamentous complex or posterior ligamentous complex, and 3. Neurological status. The subgroups under each category were assigned a score, with a higher score reflecting a greater perceived need for operative intervention, whereas a score of 3 or less suggests benefit from conservative management. The both of the SLIC score and the TLICS have been recommended by the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, owing to its excellent inter-rater reliability and ability to communicate clinical information. In the next part, I will focus on some of the advances in the management of acute spinal cord injury and some of these going controversies. The key concept that I wish to present is the role and timing of early surgical intervention for spinal cord injury. The STASI study, which was the largest prospective multi-center trial showing a beneficial role for early surgical intervention in acute spinal cord injury. The patients underwent surgical intervention within 24 hours of the injury had 3 or 4 higher rate of significant improvements in neurological function. This was published in 2017 in this focused issue in Global Spine Journal along with management guidelines for degenerative cervical myelopathy and spinal cord injury. I will summarize the recommendation as follows: that preferred management option for any form of spinal cord injury is the patient should be treated with surgery within 24 hours. The use of methylprednisolone for acute spinal cord injury has been the subject of considerable controversy, and I wish to present an updated analysis of this issue and to present methylprednisolone as a valid treatment option for spinal cord injury. Based on these papers showing the final conclusions from the meta-analysis, we suggest a small but beneficial effect of methylprednisolone in enhancing motor recovery in patients with traumatic spinal cord injury, and overall, the drug treatment is safe and does not increase the mortality and in fact slightly reduce the risk of death with methylprednisolone. We present recommendations illustrated in this slide. For methylprednisolone, when studied within 8 hours of injury, we suggest that a 24-hour infusion of high-dose methylprednisolone be offered to adult patients with acute spinal cord injury as a treatment option. We suggest not offering a 24 hours of infusion of high-dose methylprednisolone to adult patients who present after 8 hours with acute spinal cord injury. And for adult patients with acute spinal cord injury, we suggest not offering a 48-hour infusion of high-dose methylprednisolone because of the risk of complications with this protocol. IV prednisolone should be a valid option, and there is no existing evidential basis to recommend against its use as a treatment option. Ultimately, decisions should be left to the discretion of the physician, and I strongly consider the use of methylprednisolone 24 hours infusion studied within 8 hours of injury, particularly in cervical cord injury and also for incomplete spinal cord injury, especially combined with surgical decompletion. In addition to disruption of neurological function, spinal cord injury can affect sympathetic nervous system. Spinal cord injury can reduce sympathetic outflow from the spinal cord, which results in the loss of basal vascular tone below the level of injury. High thoracic or cervical injuries can lead to severe hypotension and bradycardia. The loss of innervation to lymphatic organs, such as spleen, can induce secondary immunodeficiency, which can increase the susceptibility to infections. Also, in the chronic phase of spinal cord injury, patients are at risk for the development of cardiovascular pulmonary and other medical complications that increase morbidity and decrease quality of life. The most common complications include pressure ulcers, autonomic dysreflexia, and respiratory complications, with an increased risk of venous thromboembolism, pneumonia, wound infection, and sepsis, are leading causes of acute mortality after spinal injury. The occurrence of these events is related to worse functional outcomes after injury. The most common reasons for rehospitalization in patients with spinal injury were urinary tract infections, pneumonia, and pressure ulcers. In the next part, I will discuss the emerging therapies for traumatic spinal injury, with particularly focus on stem cell transplantation. I listed emerging therapies such as stem cell transplantation and neuroprotective agents such as minocycline, riluzole, Rho inhibitor, VX201, magnesium polyethylene glycol, granulocyte colony stimulating factor, fibroblast growth factor, and these approaches are considered to hold promise for future clinical use. The slide illustrates the potential value and the mechanisms for cell transplantation in spinal injury. Cellular transplants could replace lost neuron cells, could provide trophic support in the form of growth factor stimulation, could provide immunomodulation by inflammatory microenvironment, conceptually in some cases could provide scaffold support. I would like to particularly focus on oligodendrogenic cells and neural stem cells. These have been shown most promise in clinical translation. There is a large body of work to suggest the oligodendrogenic cells derived from human somatic cells, which is reprogrammed by genetic manipulation, can provide neuroprotective role and also enhance axonal regeneration as well as remyelination. One of the potential advantages is these oligodendrogenic cells could be obtained from the patients themselves, and fast could play a role in transplantation. These cells are also considered to have another role of reorganizing neural networks, including synaptic connectivity between host and grafted neuron cells. In all cases, cumulative survival of acute spinal injury is 94% at 1 year and 86% at 10 years. Patients with complete spinal injury experience 3 times higher mortality compared to patients with incomplete spinal injury. A review of 225 consecutive patients aged 65 years and older with cervical complete spinal injury showed 100 mortality within 3 years. In a retrospective study of the predictors of early mortality, increasing age after 20 years, worsening neurological grade, severe systemic injuries, concomitant traumatic brain injury, greater number of comorbidities were identified as factors contributing to early mortality. The neurological prognosis following spinal injury depends on the level of injury and age grade, but it is often difficult to perform an accurate neurological examination immediately following injury because the patient has suffered spinal shock and may be sedated in addition to various other reasons. This figure shows the data of 3 representative clinical trials of spinal injury. It is generally agreed that performing the neurological examination at 72 hours following injury provides a more accurate assessment and may be important with respect to therapeutic interventions and trials. The timing of the exam is important because differences in motor and sensory scores from sequential neurological examinations are predictor of the patient's expected recovery. The greatest gains in motor skills occur in the first 3 months, with most recovery complete by 9 months Additional recovery can also occur up to 12 to 18 months after spinal cord injury. Patients with higher initial ASIA impairment scores experience greater degrees and faster rates of motor recovery. 94.4% with ASIA A scores initially maintained ASIA A. Additionally, 3.5% improved from ASIA A to ASIA B. 1.05% improved each from ASIA A to ASIA C and ASIA D. Between 50% and 40% of the patients with initial ASIA B scores converted to ASIA C status, up to 40% of ASIA B scores converted to ASIA D status. 60 to 80% of the patients with initial ASIA C scores converted to the ASIA D status. Based on data obtained from large prospective spinal cord injury datasets, a clinical prediction model for recovery after spinal cord injury has been formulated. Neurological function can be predicted by four pre-specified variables including initial ASIA grade, ASIA motor score, age, and MRI intramedullary spinal cord signal changes. This prediction model can be used to aid the classification of patients with clinical trials and to support physicians for predicting long-term functional outcome. Additionally, several methods have been proposed to predict functional outcome following spinal cord injury. Acquisition of diffusion tensor imaging will provide quantitative information about the integrity of the white matter, serum or CSF, cerebrospinal fluid. Biomarkers are also promising measures to predict clinical outcomes. In this final slide, I'd like to summarize the messages from this talk. I have discussed some details in the management of acute spinal cord injury, including initial care and how to evaluate the classifications. We recommended the benefits of early surgical intervention in patients with acute spinal cord injury optimally within 24 hours of the injury. I have presented a re-evaluation of the role of corticosteroids, particularly suggested methicillin would be a treatment option. And I have also discussed emerging translation-relevant neuroprotective strategies, particularly focused on stem cell transplantation. And finally, I have discussed some details of functional prognosis after spinal cord injury. Thank you.